Thank you. Just for my information, because retinoblastomas are rare and their treatment is usually centralized. And sometimes the treatment is guided by pediatric oncologists and sometimes by ophthalmologists. How many of you have experienced or treat retinoblastomas at your institution? Okay, quite many. Thank you. Good. I didn't receive the template for model 3. Okay. And yes, the retinoblastoma is the most common intraocular tumor in childhood. It accounts for about 3% of all childhood cancer. And the worldwide incidence is estimated between 1 to 16,000 to 1 to 18,000 live births. In the current study published by Didier Fabian, where he collected all cases that were diagnosed in 2017 globally, the current incidence in Europe is about 1 to 13,884 births. That means that in Europe, we've got about 300 new retinal cases a year, and worldwide, it's about 8,000 cases of retinoblastoma a year. It's a typical tumor of very young age. New patients are diagnosed up to age of 5, very rarely up to age of 8. The patient with unilateral disease, the diagnosis is about 2 years of age. With bilateral disease, the age of diagnosis is around 1 year of age, and the incidence is doubled, or the age of incidence is doubled in low-income countries, and that's important. I will talk about that later. The majority of cases develop due to biallelic alteration of RB1 tumor suppressor gene in cone photoreceptor precursor cells. And only very small fraction, less than 3%, there is a different mechanism amplification, and I will talk about that later as well. And 40 patients have hereditary retinoblastoma. That means that they've got one mutation in every cell on the body of RB1. Diagnosis of retinoblastoma, the retinoblastoma does not need histological examination, or histological examination is never done. It has the typical fundoscopic appearance, and the diagnosis is done by experienced ophthalmologists. And early diagnosis enables conservative treatment, eye salvage therapy, but when the retinoblastoma is untreated, it progresses to locally advanced and subsequently to metastatic disease. Therefore, the retinoblastoma is considered to be medical and therapeutic emergency. And in our developed countries, the survival is excellent. It exceeds 98%, and in my center, only one patient died in the last 20 years. In UK, no one died in the last 20 years. And therefore, in our developed countries, the goal of treatment is to save an eye globe and to preserve a vision. In developing countries, it's a different. Due to late diagnosis, the survival of retinoblastoma is only about 50 to 75%, and the goal is early referral for any treatment, any means, usually enucleation. And this is the typical presentation. The leukocoria is present in 60% of patients, and leukocoria means that there is a white reflex, open illumination through the pupil instead of normal red glow by a normal retina. This is the tumor here. Another tumor, retinoblastoma, is seen there, and the strabismus is second most common presentation. It occurs strabism when the tumor covers the macula lutea. It's the center of the retina where is the most precise and accurate vision. For example, because our vision is, let's say, canalicular. When I look at you, I see you very clearly, but here I still know that there is a hand, but I won't be able to read there anything. For example, when I look at you, I see you clearly, but still, again, I won't be able to see here. Therefore, macula is very important for our vision. And kids do strabism not due to any muscle infiltration, but because they are trying to put the normal retina to the axis of the vision. And this leukocoria and strabismus is usually seen in normal family photos. This is how the tumor, this is the fundoscopic examination, with photograph of a RETCAM, where is a tumor mass with large vessels and large vessels on it. And this extraocular retinoblastoma or advanced retinoblastomas are rare in developed countries. Less than 3% of patients present with this disease, according to the literature. So the diagnosis is done by ophthalmologists with direct ophthalmoscopy, with scleral depression under general anesthesia. It's important because general anesthesia, it's important to look also to the periphery of the eye. And ophthalmologists always do the photography. Here is the tumor. He counts, the ophthalmologist describes the tumor, describes exactly where the tumor is. This is the tumor covering the fovea, the macula lutea, where is the most accurate vision. This is the retinal detachment that is also described by the ophthalmologist, and this is the seeding. Seeding are the free tumor particles floating in the vitreous or subretinal. There is the subretinal seeds. The fundus, they always do the fundus photography, and the biomicroscopy helps, or ultrasonography helps to describe the anterior or posterior chamber of the eye, and these calcifications are pretty typical for retinoblastoma, and optic coherence tomography gives the trans-sectional view of the retina. It enables to diagnose the small tumors. It helps with follow-up during the treatment. It helps to identify the scar. And nowadays it's considered to be also the routine examination during the ophthalmological examination. And the CT is no longer done. The standard is high-resolution MRI with contrast agent, where the special cone that is placed to the proximal of the affected eye is used, and it helps with differential diagnosis and to confirm the diagnosis of retinoblastoma, and it helps us to identify the risk factors like optic nerve invasion or trilateral or metastatic retinoblastoma to the CNS, and also the massive choroidal invasion. It's always important to correctly orientate the MRI pictures to be pretty sure whether there are or no the risk factors. And the classification or the staging. The Svojgr classification is no longer used. It was used when the retinoblastoma were treated with external beam radiotherapy. Nowadays we use intraocular staging of retinoblastomas, ERCB, when A is a small tumor somewhere in the periphery. Here B is still the small tumor, but covering the macula. Therefore, these patients then compromise the vision. C is the bigger tumor with a small seeding, not exceeding 3 millimeter. D are the large tumors with excessive seeding. E are the biggest tumors within the eye that occupies more than 2/3 of eye globe or infiltrates the secondary structure of the eye. And again, here are the better pictures: small retinoblastoma A, B at macula. C, maybe you can see here the cloud of small seeding. D, the large seeding, and E is the largest tumor. International retinoblastoma staging system covers the whole spectrum of the disease. Stage 0s are patients treated conservatively. Stage 1 means that the eye was enucleated but completely resected histologically. And from stage 2, the complete evaluation should be done. Stage 2 is eye enucleated but with macroscopic residual tumor. Stage 3, regional extension to overt orbital disease or metastasis to the cervical lymph nodes. And 4 are the distant metastasis. For A, hematogenous metastasis, usually to the bone, and stage B are the metastases to the central nervous system. Therefore, from stage 2, the patient should have the lumbar puncture, bone marrow examination, we usually perform PET CT or PET MRI. This is the patient with metastatic retinoblastoma that was treated at our institution. And currently, the most, maybe the most precise staging is TNM classification, but until now, it's not so widely used. Therefore, I won't use this TNM classification in my presentation. On histology, this is here. This is the well-differentiated retinoblastoma with, I think it's Flexner-Winterstein rosettes. This is poorly differentiated retinoblastoma. Here is the risk factor when the tumor invades behind the lamina cribrosa to the optic nerve. Here again, the lamina cribrosa and invasion of retinoblastoma to the optic nerve. This is the invasion of retinoblastoma to the anterior chamber and to the iris. This is the massive choroidal invasion that is more than 3 millimeters in any direction by definition. And this is massive choroidal invasion with scleral invasion. These are the risk factors. On biology, there are 2 types of retinoblastoma, but actually 3 types. And that they can be distinguished by methylation profile. The retinoblastoma is caused by B allelic mutation of retinoblastoma gene, and this mutation by itself does not cause the retinoblastoma. These mutations led to overexpression of MYC, alteration of p53 pathway, and to cause retinoblastoma type 1 that is more differentiated. Another genetic changes has to occur. Most common are copy number alteration of 6p, 1q, 2p, or 16q minus. Some single nucleotide variants like B-core amplification, CREP, and the other. And this is type 1, well-differentiated retinoblastoma, and we think that there is a continuous to the type 2 retinoblastoma, again identified by methylation profile, when these tumors usually have anemic amplification and are more aggressive. And the third type, that is not very common, have normal RB1, but is caused by anemic amplification. This type occurs in very young kids, has very aggressive behavior, and yes, and accounts less than 3% of retinoblastomas. As I told you at the very beginning, retinoblastomas are never biopsied, but nowadays analysis of free circulating DNA is still investigational, but we believe that soon it will become standard. We can sample the aqueous humors from anterior chamber of the eye, where usually are no retinoblastoma cells, and this analysis of FcDNA can help us to identify the subtype 1, subtype 2, and also to identify these genetic alterations. And it can be used to assess the therapeutic response, whether there is any residual disease, to early detection of recurrence, and in peripheral blood, in plasma, it can be used to analyze whether there is or no the risk of metastatic disease. As far as I know, no targeted drugs are still used in treatment in retinoblastoma. As far as I know, there is even no clinical study analyzing SYK inhibitors or M2 antagonists, but nowadays it's debated. And I think that soon some study will appear. And to the genetics, RB1 is a typical, or Knudsen modulates his model using the RB1 mutation. Therefore, to have the phenotypically changed ball alleles have to be silenced with mutation or by some epigenetic silencing. The hereditary retinoblastoma has penetrance about 90%, and there is some genotype-phenotype correlation. That means that how much is the protein truncated, the more severe phenotype exists. And there are, in fact, three types of hereditary retinoblastoma. Familiar hereditary retinoblastoma that is inherited with autosomal dominant trait. Isolated sporadic hereditary retinoblastoma, the new mutation in approximately 40 cases. These tumors are frequently bilateral. There are usually multiple tumors. The median is about 5 tumors. Patients with 13q syndrome have not only the retinoblastoma, but also some developmental and mental delay. And the mean age of diagnosis is, as I told you, about 1 year. Also, there is the mosaic form, the retinoblastoma, there is no severe. This non-heritable retinoblastoma is about 60% of cases, and they occur in approximately 2 years of age. It's very important to do the genetic testing in every patient because it's important not only for follow-up during the treatment of retinoblastoma to follow up the other eye, but also because of the risk of subsequent neoplasm during the life. I will talk about that later. And what are the goals of retinoblastoma? Here, to save the child of retinoblastoma, to salvage an eye, to salvage a vision, and to prevent the secondary neoplasm in hereditary retinoblastoma. I have to say that there are no randomized studies in retinoblastoma. There were no randomized studies ever done. Everything is just from a single institution studies or usually, yeah. And last year, the first randomized study was published, but there were the Chinese authors who randomized the systemic and intra-arterial chemo, but these studies have some drawbacks in methodology. In history, the retinoblastomas were treated, the unilateral disease, the eye was enucleated, and in bilateral disease, the more affected eye was enucleated, and the second eye was salvaged with external beam radiotherapy. First, the systemic chemotherapy was used in 1994 when they used the treatment, where they used to treat retinoblastoma, the chemo that was used for neuroblastoma. And this was the seminal publication by Philadelphia group published in JCO when they used the standard chemotherapy up to 9 VEDS, carboplatin, etoposide, and vincristine. And it, along with local ophthalmological therapy, it leads to survival about 60% of eye bulbs. This is event-free survival of the eye bulbs, meaning that patient was not enucleated or didn't underwent external beam irradiation. And these are our data from our hospital when we looked back, when we used this type of chemotherapy from 1999 to 2014. We have treated 101 affected eyes, and this is ABCDE from the smallest to the largest, and here are the absolute numbers. And here I would like to show you that first, usually the affected eye is usually advanced because you have to see there the leukocoria or strabismus. These AB are usually patients that had the bilateral tumor. There was when in one eye the retinoblastoma was advanced, and the second eye there was a small tumor. And also to show you that we usually failed to rescue these advanced tumor. Enucleation. Enucleation is a good option in treatment of unilateral retinoblastoma. Most intraocular retinoblastomas can be cured by enucleation only. Still, when you have someone with locally advanced unilateral retinoblastoma, today there is no standardization and no clear indication which patient should be attempt to be salvaged with therapy and which patient should be enucleated. When there is when there are no risk factors, that means focal corridor, no corridor invasion, no involvement of the optic nerve, or no aqueous seeding, and even when this is present, the patient doesn't need to be treated with systemic chemotherapy. Intermediate risk factors, the patient should be treated, but it's still debated. Is massive choroidal invasion, that means more than 3 millimeters in every diameter. Scleral invasion, this patient should be treated with systemic chemotherapy. And postlaminar optic nerve infiltration, this patient should be treated with systemic chemotherapy. When there is extraocular disease or infiltration of resection of the margin of the optic nerve, this patient should be treated with systemic chemotherapy, followed by orbital irradiation, but this is very rare at our countries. Most patients are treated by, most can be saved by enucleation alone in unilateral retinoblastoma. This is the treatment that is done by ophthalmologists, ophthalmological treatment. Laser therapy, photocoagulation, they use the green laser and they burn out the retinoblastoma in the posterior of the eye. Cryotherapy, the triple freeze thaw technique with cryoprobe is for treatment of pre-equatorial tumors, and brachytherapy is set up to give 40 grays to the apex of the tumor. And usually chemo goes along with, or systemic chemo goes always with this local treatment by ophthalmologists, and intraarterial chemotherapy sometimes has to be also followed by this ophthalmological therapy. And this intraarterial chemotherapy completely revolutionized the treatment of retinoblastoma. It's the selective delivery of high-dose drug to the eye with minimal systemic exposure. It was introduced by Dr. Abramson in New York, but before the Japanese group also used this, but using the other technique with balloon. This is the classical technique is drug injection directly to the ophthalmic artery through transfemoral catheter. Is done by interventional radiologists. When through the groin with microcatheter, they bypass the heart, and this is the ophthalmic artery where they put the microcatheter, and then the cytostatic is infused. Yeah, and these are the video. Yeah, this is brain angiography, and this is the ophthalmic artery. It's this one. Maybe you can see this is the catheter, and right now, hop, it's there at the ophthalmic artery. Again, to show it, yeah, this is the microcatheter. Going down and now up, and it's there. And this is what we want to see when we do the angiography of the ophthalmic artery. The contrast agents go eventually here to the eye where we've got opalesque of a choroid. In this case, we can give chemo, but sometimes it occurs in this way when the majority of contrast agent go up to the brain, and the rest that goes to the ophthalmic artery go up to the nose and to the upper forehead. And in this case, it's useful. It's not useful to give the cytostatics. And when it is correctly done, the responses are excellent. Here are the regressions of retinoblastoma on a red cam. The tumor can shrink up to this size. This extremely large tumor can shrink to this size, and it's the same. The same picture on MRI. The response can be excellent, but this procedure is not totally standardized. And sometimes when you discuss with big bosses, or how to call that, about intraarterial chemotherapy, it has nothing to do with scientific discussion. It's something like more religion. What are pros, what are cons, which drug to use, and yeah. Some centers use one drug, that is melphalan, this is mostly commonly used. Some centers also use carboplatin and topotecan. Some use 2 drugs, some use 3 drugs. No one knows how long it will be infused, for half an hour or for 10 minutes, who knows. There are standard versus alternative use of catheterization. I showed you the standard use, but you can also use the vertebral arteries, arteria cerebelli media, And there is always a learning curve and the risk of severe complication. This is per se the this is the brain intervention. Therefore, there is always the risk of ischemic or hemorrhagic stroke. And during the procedure, you have to be prepared that in up to 25 procedures, there is a bronchospasm. It's some reflexive bronchospasm that occurs because some innervation of dura, and you absorb bronchospasm, as is very common. When you occlude the artery, or when melphalan has to be filtered, and if not filtered melphalan, when you occlude the retinal artery, you can cause the retinal ischemia that's on this picture. When I show you the bypassing of the contrast agent, it can lead to ptosis. This girl eventually had the eye enucleated. It can lead to forehead erythema. Yes, there are some steps to avoid it, like nasal constriction or something like that, but still it's not standardized. And it's a skioscopic procedure. Therefore, there is always the risk of radiation-related toxicity. The other common method is intravitreal chemotherapy. It's a direct application of melphalan or topotecan to the vitreous cavity. And this technique was published by Lausanne Group, by Francis Mounier in 2017, and it's very effective for vitreocytes. The technique is with cryotherapy of the needle tract to avoid the possible dissemination of the retinoblastoma through the tract that was done by the needle, and it's almost 100% effective in a disease control. And this is the slide that I just captured at our meeting of European Group of Retinoblastoma, where Dr. Shields from Philadelphia, Carol Shields, presented the cumulative data or data that she accomplished from the large US center. And you see that in comparison to our experience with systemic chemotherapy, here you see that the method is extremely potent, even in retinoblastoma E eyes. And the primary intraventricular chemotherapy, again, is very, very effective. But as I told you, this method is not standardized. The other issue is the visual acuity or what happens with the retina during the retinoblastoma treatment. This is the small tumor at the very beginning. This would be retinoblastoma A. This is after the first laser photocoagulation. Here is the still active tumor. This is after the second laser coagulation, still small active tumor, and this is the end of the successful treatment. There is a scar. And where is a scar, there is no normal retina to enable vision. Therefore, in a small retinoblastoma A, there is no problem with that. But for example, retinoblastoma C, you see that the scar is exactly on the macula lutea. And this large retinoblastoma E, there is virtually no vision. And again, these are our data where when we look to the retinoblastoma A, the visual acuity is about 1. Vision 1 is here. It's this on the synoptopty, we already know it, and this is the best corrected vision. Therefore, that means that the patient has his glasses on, and this is the best corrected vision. So it's good for small retinoblastoma, but still for retinoblastoma B that covers the macula, the vision is 0.3, it's 0.4, it's somewhere here, and the large retinoblastoma, there is virtually no good preserved vision. But when you hear the lectures from Dr. Abramson, he will always show you some case presentation when the patients with large retinoblastoma have excellent vision, but it's not always true. And the other issue I want to show you is the number of general anesthesias for retinoblastoma treatment. This is the excellent study that was done by Didier Fabian. He just counted the number of anesthesia of the patient that were treated with primary enucleation for unilateral retinoblastoma. There was the median of 9 general anesthetization, one for the diagnosis, the second one for the MRI, the third for enucleation of the eye bulb, and then subsequent MRIs for follow-up of the patient. When the patient was treated conservatively with intravenous chemotherapy and local ophthalmological treatment, the median of anesthesia was 20. Therefore, the patient had every month general anesthesia for treatment and then for all of follow-up. Therefore, we have to compare what's better at the very beginning, to enucleate NI in retinoblastoma or to go through the treatment that can have in median or mean 20 anesthesias. And this is just to show you, this is from the publication. This is just to show you how many anesthesias the patient had during their age, from the birth until here is 140 weeks is the end of the axis. Yeah. The other issue is advanced retinoblastoma, trilateral retinoblastoma, metastatic retinoblastoma, or locally advanced retinoblastomas. These retinoblastomas are considered to be incurable in history, but in 2000, I think it was published, it's not written here, but it was published in 2020, the COG study RN0231 with very intensive chemotherapy with stem cell transplant, autologous stem cell transplant, and the patient that does not achieve a remission during the induction chemo, also irradiation. It, let's say, again revolutionized the treatment of retinoblastoma, that except of the patient with metastatic disease within the CNS, the patient with systemic metastasis or with locally advanced retinoblastoma, they can be salvaged using this very intensive chemotherapy. In hereditary retinoblastoma, there is always the risk of secondary malignancies, and the risk is calculated to be 1% per year. That means that at the age of 20, the risk of secondary malignancies is about 20%. The risk of 40, the risk of secondary malignancies is about 40%. It's not, and nowadays it's not so high, or we believe that it won't be so high because the patients are not treated with irradiation and they are not treated with alkylation cytostatics. Here are the lines or the graphs that shows you that this patient was treated with irradiation, and these patients were treated with irradiation, and this patient was treated with irradiation and alkylator cytostatics. The risk of bone tumors was higher. The risk of leiomyosarcoma was significantly higher, etc. There was no difference in the risk of melanoma and epithelial tumors. And what are the second cancers in retinoblastoma? In early childhood, it can be the pinealoblastoma or trilateralization of retinoblastoma. It occurs in approximately 3.5% of hereditary retinoblastoma. It can be synchronous or metachronous. Metachronous means that it's longer than, it's more than 1 year after diagnosis of retinoblastoma, and children with hereditary retinoblastoma should have the head MRI until the age of 4 years. In adolescence, the patient can suffer osteosarcoma, soft tissue sarcoma, and those who were irradiated, they can have the tumor of nasal cavities, and in middle age, many have they can have melanoma, breast carcinoma, bladder carcinoma, CNS tumors, and the other. What's biggest important is to have the patients enucleated, to have them well educated, to understand. Sorry, to have them well educated, to understand what are the symptoms, and to go to the follow-up clinic as soon as they realize that they have some bone pain that does not really within the 1 or 2 weeks, some tenderness, headaches, or have some signs of increasing intracranial pressure. And especially at the high risk, the patients that were treated with external beam radiotherapy. Patients with hereditary retinoblastoma should have an annual visit at long-term follow-up clinic. The whole body MRI was discussed, but it's no longer recommended because it produces many false positive results, and we also did a whole body MRI, but it was very difficult to to get rid of these many false positive results. And so I told you, we believe that the incidence of second cancers will be less in patients with retinoblastoma when they are not treated with extended radiotherapy and alkylating agents. And my last slide is about global retinoblastoma, because in Europe we've got about 300 cases. In US there are also about 300 cases of retinoblastoma a year, but in general, the global incidence is about 8,000 of cases. And in Europe, the survival rate is about 98%, but in Asia, the mortality is about 15%. In Africa, the overall mortality is about, it's 1/3 of patients die. And this is here Didier Fabian published in this publication, Lancet Global Health, and there is an initiative called Global Retinoblastoma, where they try to help the developing countries, because most patients can be cured by enucleation only. They have the bad survival due to late diagnosis, due to premature stop of treatment, due to no follow-up, and also in some countries, some cultural regions, the reluctance for enucleation. So to conclude, the retinoblastoma is tumor of early childhood associated with RB1 gene mutation. It's a high curable disease in developed countries. Introduction of modern therapies like intra-arterial, intravitreal, and also intracameral chemotherapy revolutionized the eye globe survival. Hereditary reproductive survivors have increased risk of secondary cancer. Molecular biology and analysis of DNA enables non-invasive diagnosis, and also to monitor the response to therapy. And I think that the primary enucleation is still a good option, a treatment option in unilateral retinoblastoma.
Questions?
So just because we had a case lately, so no possible intra-arterial therapy, no good response to chemotherapy. What is second line? What would you suggest?
No response to intra-arterial, no response.
No, intra-arterial not feasible.
Not feasible, yeah.
And no good response after 6 cycles of vincristine, carboplatin, etoposide.
It depends. It depends whether there is the seeding. What's the problem? That, yeah, usually these patients, the seeding, there are free tumor particles within the vitreous that are not reachable by systemic chemo. This is, yeah, the non-response of the seeding is usually the biggest problem. Therefore, maybe this patient is the candidate for intravitreal therapy. But what is discussed is when to stop the treatment and when to go to the enucleation. And again, it's not standardized. You never know, because you can still have, you can use the alternative route for intra-arterial chemotherapy. You can use intravitreal chemotherapy. You can continue with local therapy on an ophthalmological clinic. But when to say it's enough, the patient should be enucleated, is sometimes difficult to say, is discussed. We don't do it. It's general recommendation. It's discussed, but you know the incidence of trilateral retinoblastoma. It's only 3%, and it will be published by Pim de Graaf from Netherlands that you have to do 800 of MRIs of magnetic resonance to save one life. Therefore, and there will be no guidelines published at the end of this year or at the beginning of the next year. And yeah, right now the general recommendation is do head MRI every half a year, but we don't do it. And I know from personal communication with PIM that they have to be 800 MRIs to save one life. Therefore, we don't do it at my institution. But the recommendation is different.
So, are you aware of any follow-up studies on neurocognitive development in those who have IAC treatment compared to the ones who are enucleated early and giving systemic treatment?
Yes, it exists, but it's difficult to present it because there are huge tables that I don't understand. Yes, there are studies.
Any other question?
We still have 5 minutes.
Have you had any problems with spasm of the ophthalmic artery, and have you noticed it's correlated with the type of chemotherapy? Because I think in Birmingham they kind of switched from, I can't remember if it was Malflam, stopped using, because they had some problems with that, and they wondered if it was correlated.
Actually, yeah, it's discussed. But as I told you, when you are trying to discuss these tough situations with for example, with Dr. Abramson, it's not a scientific discussion. It's something like to discuss about religion. Therefore, yeah, it's discussed, but yes, melphalan is irritative. It can cause it. Yeah, we use melphalan in my institution, and we know about the bronchospasms, and the anesthetist knows about that, and they are we are prepared for that. That's only what I can say.
I wanted to ask about metastatic disease. So we had one case of a child from Romania who had metastatic disease at presentation, and we were sort of told that you never see metastatic disease, so nobody really knew what to give. And she ended up receiving kind of quite intensive Head Start style chemotherapy. I just wondered what your experience is of treating metastatic disease.
Yeah, we got also only one patient, and the patient survived, but the chemo was, I discussed it with Guillermo Chantada, you know it well, everyone, and he told me at the very beginning that be careful because this chemo is very toxic, and it was very toxic. It was, yeah.
What did you give, sorry?
We give the SIOP study, RET 0321, that's, I don't know by heart what cytostatics are used, but yeah, even with autologous transplant, yeah, we gave this study. It's vincristine, cisplatin, cyclophosphamide, etoposide, and the thiotype etoposide are used for transplant. Okay, thank you.
Thank you.